thank you, and I'll hand it over to Dr. Matovu.
Thank you. Thank you for the introduction, Laura. What she didn't mention is that in 2001, while I was at Johns Hopkins University, we had a trip to the Twin Towers when they were still around, and I went up to the top. That was about July 2001, and then in September, they were hit. So I missed the heat by 2 months. So it's like we could have been there, you know. Okay, this is my work in the fishing communities in Uganda. And what we are doing there is basically okay, thank you. So this work is in the fishing communities, and what we are doing is a peer-led HIV self-testing intervention. Peer-led because we work with local people in the communities. These are trained as peer leaders, and then they facilitate the distribution of HIV self-test kits in the fishing communities. So social network strategy is actually one of the strategies that have been adopted by the World Health Organization for reaching key and priority populations. But at the same time, there's now evidence coming through that the same strategy can be applied to the general population. I'll be referring to a recent systematic review that was presented at IAS 2023, where there is additional evidence to indicate that now the social network strategy can be applied to the general population. The original evidence was only for key populations. So the social network strategy is an evidence-based supported approach to identify, engage, and motivate people with undiagnosed HIV infection to accept HIV testing. And the social network strategy is based on the underlying principles that people in the same social network share the same behaviors that increase the chances of getting or transmitting HIV, and they know and trust each other. So our social network-based peer-led intervention is informed by this thinking. So this is just an illustration of the social network-based strategy to HIV testing. You can have unlimited waves, you can have limited waves. So people go on, one person can lead you to many people, and in some kind of snowballing or respondent-driven sampling. But so the same approach applies here, where one person can get you to the social network and you get to other people within that network. So the current evidence that social network strategy can be applied to general population comes from a systematic review by Ong and others, which was presented at IAS 2023. They compared the social network strategy to non-social network studies, and then in conclusion, they found that the social network strategy, compared to other testing approaches, showed uptake of HIV testing may be higher among social contacts or partners of test promoters, and then the proportion of first-time testers could be probably higher, and the proportion of newly diagnosed people may also be higher. So in other words, the social network strategy was found to increase HIV testing uptake. No studies reported serious adverse events or social harms linked to social network strategy, and the World Health Organization is planning to update the 2019 guidelines on social network strategy to include the general population. So we hope that our work also contributes to that arrangement. So what I'm going to talk about is the PEST for men, which is peer-led self-testing intervention for men. This intervention was informed by our previous work on HIV self-testing in the fishing communities. We started off at a place called the Kasensero Fishing Community. For those of you that are interested in HIV/AIDS research, if you scroll back to the first cases of HIV/AIDS in Uganda, they were identified at this site called the Kasensero Fishing Community. It's a fishing community along the shores of Lake Victoria, and there were infections coming through from Tanzania, and most people were infected around there, 1980, 81, 82 there. and then they spread, the infection then spread throughout Uganda. So we did our first studies in this community, and these are the papers that were published out of that work. The first paper was published in BMC Public Health, which was a formative research to inform the development of this intervention. And then we also published another study that described the feasibility and acceptability of this peer-led HIV self-testing intervention. And then we also published on the peer leaders' experiences and challenges in distributing HIV self-test kits in a rural fishing community. I should note that this work of peer-led HIV self-testing, I give credit to Laura, who is here, because I worked with Laura in 2006, 17, 18 there, and she had come to implement the Game Changers, which is really focused on working with HIV, people living with HIV and training them as HIV prevention advocates. So because I was working with her, I picked the idea. Now I turned it to peer leaders in the fishing communities. For her, it was HIV prevention advocates. Then when I designed the intervention, I actually turned it to peer leaders. So I give credit to Laura because I borrowed the idea without permission. I borrowed the idea because I was supporting her on one side, and then I was like, oh, this is a strategy I could use somewhere else. So I picked that and took it to the fishing communities. And if you look at the second present publication, published in PLOS ONE, you will see her name as second author on that paper, because I wanted her to really bring in the HIV experience into this paper. So thank you, Laura, for that. And I'm actually now moving forward with this kind of work. So why did we target the fishing communities? Fishing communities have high HIV prevalence and incidence based on the literature than the mainland communities. And there is evidence that they have been dubbed as net sinks. If you see these illustrations, you see more lines getting to the fishing communities than those that are getting out. Initially, we used to think that because they have high HIV prevalence, they would be the source of infection to the mainland communities. But the evidence that is coming through is that actually more people, especially in our countries, when people get HIV and get most of them will run to the islands, to the land, to the fishing communities. So that's why you have so many people there who have HIV. So in a way, they become net sinks, and therefore there's need really for interventions to protect those that are not yet infected, to remain negative, but also to reach them with HIV prevention services and treatment services as needed. So this is study focused on men living and working in the fishing communities. And we use the generic definition of men. Any person who was male by identification was considered for this kind of study. So the purpose of the study was to assess feasibility and acceptability of a peer-led HIV self-testing intervention on HIV testing uptake, but also had secondary objectives, namely to assess the preliminary effects of this intervention on HIV self-testing uptake and linkage to care, and also retention in care among men living with HIV. We also assess the acceptability of secondary HIV self-test kits distribution from men to other men within their networks. So by feasibility, we wanted to measure this as a function of the peer leaders' ability to successfully distribute the kits to other members of the social networks. What I should say is that the peer leaders we're talking about are local people, people who probably have gone up to primary level of education or lower secondary level of education. They are usual people in the communities. But since they are leaders within their respective groups, we train them as peer leaders, and therefore we can use them to reach their networks. So the intervention was deemed feasible if peer leaders distributed up to 70% of the kits they received. Now, this is a community where you have people who live together, and you pick out one and you train them as a peer leader. Then you give them HIV self-test kits to distribute in their communities. The question is, will the other people they have been living with accept to take the kits? They would say, this is Joseph, who have been drinking every evening with him. How can he come in and start distributing kits? So I wanted to find out, will people really accept to take the kits from these people? And two, will they be able to use and return the used kits? Because we wanted to look at the used kits to be able to tell if they read their results correctly. So we thought if 80% of the network members returned the used kits, then we would be saying, this is something that's feasible in this location. Then acceptability was defined as the percentage of social network members who received and used the kits. Because there's one thing taking the kits from your peer leader, and then it's another thing to use them. And so one will find out, will they use them or just pick them, take them home and then return them unused? I will tell you what percentage you return them unused. So the intervention was deemed acceptable if more than 80% of social network members were comfortable to receive the kits from their trained leaders, and more than 80% of those that received the kits from their peer leaders used them to self-test for HIV. And we looked at the primary intervention effects as being the proportion of men with a reactive self-test result who were first-time positive testers, and proportion of first-time testers who went for confirmatory testing, and a proportion of those who went for confirmatory testing confirmed as living with HIV who were initiated on treatment. And then would follow through to see how many of them were retained in care. So secondary distribution, we define this as percentage of men who received the 2 kits, because we would give 2 kits, and then we would follow through to find out of those who got 2 kits, how many gave them out to other people in their networks. And if we found more than 80% of the secondary recipients accepted to take the kits, then we would know that secondary distribution is possible in this setting. So how did we do this? The study was conducted at Kasensero, Kalangala and Buvuma districts. I'm going to show you the maps. So Kalangala district is that one you see in the circle. It's an island district. You have to use a ferry to cross and get to the islands. And that's what we used to do during the study. And it has a population of about 1,200 people, and 58% of them are male. So the main occupation is fishing and the fishing-related activities, working in the oil palm plantations and other activities. And then the second site was Buvuma, which is also an island district. That is Buvuma in the lake. We are working in the Lake Victoria region. And this has a population of about 1,000 people, 60% of them male, and economic activities include fishing, fishing-related activities, border cyclists. For those of you that have been to our places, border are these are guys who use motorcycles for transportation purposes, and you have to pay. So they are, in our place, they are called border because they used to help people cross the border from Kenya to Uganda. They carry stuff and cross the border. So somehow the word was localized to border, but they were actually referring to a border between 2 countries. So those are the guys. And now this is Kalangala. So I wanted to show this to you so that you see that these were 2 places that were far apart. One, the lower one is the one I showed earlier, Kalangala district, and then the upper one is the other site where we conducted a study. So this intervention was social group focused. We focused the social groups. As you can see in the illustration, the group can have so many people. And so we targeted a social group and then identified one person within that group. And this person was trained to reach other members of the group. And then, but before we intervened, we had what we call the pre-intervention activities. One, we had community entry meetings with the stakeholders. You don't just come in and start your research. And then number 2, we conducted formative research to understand the nature of groups, who is relating to who, and who can be a leader, and that kind of stuff. And also, we picked the perceptions from the people about the kind of intervention we're bringing in. Would they allow that kind of intervention? What would they suggest? And so on and so forth. So we picked that information, but also used this step to identify the groups that existed, groups of men who work together, groups of men who live together or live together, and then we would target those men. And the third approach was to select the peer leaders from those respective groups. So the community members were convened in meetings in the communities and to select one as a peer leader. So each group had to convene. You had one group there, the other group the other side, another group the other side, and then they all had to follow the same criteria. That is to say, pick somebody who is 18 years of age or older, pick someone who can keep secrets and is trustworthy. These are things that we picked from the formative research, but also reinforced through literature about the social networks. So pick someone who is known by the members of the social group and pick someone who is able to read and write in English. So we were able to pick 22 peer leaders from across the 2 districts, and these were trained in how to perform HIV self-testing, how to distribute the kits and fill in the relevant forms. We gave them best counseling training so that they can be able to, provide best counseling to their members, and also effective communication skills. Each peer leader was asked to select 20 social group members because our initial interaction showed that, and also literature showed that men could be able to identify at least 20 men from their respective networks. So then we trained them to distribute the kits. Now, each peer leader was asked to nominate or refer to the study 20 men, and then we would screen them and enroll them in the study if they were found to be eligible. To be eligible to be enrolled into the study, the person referred to us, who we are calling a social network member, had to be HIV negative or of unknown status at the time of enrollment, last tested for HIV more than 3 months ago. Why is it more than 3 months ago? Our HIV testing policy recommends HIV testing every 3 months for people who are high-risk groups, and the fishing communities and the people who live in those communities, because of high HIV prevalence and incidence, are considered high-risk groups. So they should have tested more than 3 months ago, because we thought if we are within the 3 months range, then you should have tested, given the guidance that we have from the ministry. They were supposed to be 15 years of age or older, known as a member in a defined group. So we identify you as a peer leader. If you bring your 20 people, we first ask them whether they know you. Are you known to each other? And then we had a series of questions that would use to tell whether you actually an impositor, somebody who is claiming to belong to this group when you don't belong to that group. And then you should be personally known and close to that peer leader, and also intended to stay in the community for 12 or more months, because we had multiple follow-ups to make. We checked what is called cross-social group membership, because in the fishing communities, somebody can be a border cyclist, but they belong also to the fishermen's group. They are also doing other things. So you see they could belong to multiple groups. So after selecting the men, we would now convene with the peer leaders and say, these are the people you have given us. These are the people that are qualifying to get into the study. Tell us who of these belongs to another group. And then we can see that we retain only unique individuals within each respective group. So peer leaders received a list of the group members who had been successfully interviewed, because whoever was whoever was eligible was enrolled and interviewed, and then we gave out a list of those interviewed to their respective peer leaders. So the intervention actually entailed the distribution of kits by the peer leaders, and the peer leaders had to fill an HIV self-testing distribution log just to be sure that they actually did the distribution. The photos you see on the side indicate somebody trying to get their kits. We had those bags, and then you would have as many kits as possible for your respective group. Distribution happened mainly at the peer leader's home, or in the social network places, social group members' home, or in the workplaces. And each peer leader was given self-referral cards that they gave to the members. And these self-referral cards were to be used by those who tested positive, and they would bring them to a health facility or linked to a health facility. And then they would be confirmed, their positive results would be confirmed before they could be enrolled to treatment. So these are the results. We had, like I said, we had 2 sites, one in Kalangala, one in Buvuma. So we enrolled a total of 400 men, and we had numbers dropping each visit, as you could imagine. Some of them were actually mobile. By the 3rd follow-up visit, we had 63.5%. So probably 36% lost follow-up. This is high, but not surprising, given that men in these communities are largely mobile. Our losses to follow-up were largely due to out-migration, people moving out of their communities. A few people refused to participate in subsequent interviews, but we had 24% wrongly enrolled. This is something that I will describe a little later. Wrongly enrolled because initially, because we are using a self-report in terms of assessment. How long ago did you test for HIV, and what was your last result? Somehow community members got to know that when you go and tell them your last result was HIV positive, they will not enroll you. So they would come and say, oh, I'm negative. And then we ended up enrolling 35 men, this is 24% of those who are lost follow-up, not 24% of the entire sample. 35% is a small number because we are enrolling 400 men. So that's I needed to make that clear. Then there were other reasons why either you follow them up and the phones are off, and those was 35 men. So in general, about 146 men were lost follow-up subsequently up to the last visit. So this is the group. You may not be able to probably know the groups are written in local language, and we just did a starter output. These were the groups. We had so many groups, and in each group we could enroll 23, 25, 30. So the numbers kept varying because in some groups we had more than one peer leader, so the numbers would vary, except that group shown in yellow, which had basically older men, 50s and above, and these were very difficult to get, and most of them were living with HIV. So we ended up eliminating almost all of them. So remember, every report person would give 20 men, but then we could only enroll 7. But even when we tried to look further, the 7, these are the people that we found that were telling us they were negative when they were HIV positive. So we end up dropping them from the analysis later on. So the men were generally young, 25 to 34, and education level was primary level of education. Occupation, about 38 were fishing and 18 were fishing related. There were other occupations. People were not only doing fishing, they were also doing other business and other occupations, and 82% reported they had ever tested for HIV. Feasibility, which is one of the objectives, was to assess feasibility. We assessed feasibility by looking at how many kits we gave out and how many were distributed. So we gave out 800 kits, and each person had to get two kits from a peer leader. And of the 800, 97.7% were distributed. So which was one of the pointers we're using for assessing feasibility. So it was possible that you could give people kits and they distribute them through their networks. And when we interviewed the men who received the kits at follow-up 1, we found that 98% of them reported that they received at least one kit from their peer leader, and 70% received the kits within 1 week after the baseline interview. So it's really possible. You can trust these guys. They can take the kits and they can give them out, probably within the shortest time possible. The other 30% of the kits distributed that came in after 1 week were for men who were always probably mobile and not around wherever their peer leaders looked for them. So how comfortable was it for you to receive the kits? We wanted to test this because, yes, we're using this approach and most kits were distributed, but were people really comfortable picking the kits from these men? 88% said they were comfortable to receive the kits from their peer leaders. And when we asked whether they would recommend that HIV test kits continue to be distributed by peer leaders, 98% said they would recommend that. So to us, that was important to say, this is something that is feasible and that we could distribute the kits through these people. Now, in terms of acceptability, we measured acceptability in terms of whether they use the kit, those who received the kits actually used them. And we found that 99% of the men that received the kits used them to self-test for HIV. And use of kits did not differ by age group, education, occupation, or other testing status. 96% returned they used the kits for the reading by a member of the study team. We wanted to use the kits, look at them, and then we'll compare. What did you see on the kit? And then what is the study team member seeing on the kit? So that we are able to tell if they read the results correctly. 3.7% returned the kits unused. About 13 men took the kits, but returned them unused. We did not go into why they returned them unused, if I remember, but it was their opinion. I think some of them, if I remember, were like, I was already positive. Some of them, I think I agree that I was already positive. I realized that I would be wasting your kit, so I decided to return it. Yeah. So what were the common mistakes that men made during testing? forgot what to do was the highest at 7%. Forgot to time the testing exercise. You have to time at least 20 minutes. You should be able to read the results. 6.8% say they forgot to time. 6% say they read the results before 20 minutes. They were probably a bit apprehensive. You had to keep checking and see what is coming up. And then 5% failed to open the package to remove the kit and probably were helped by somebody else. And then some 3% passed the kit on the teeth. The instruction is that you pass on the gum, upper gum, and then you turn and pass on the lower gum, not on the teeth. We have had cases where people have either, they just spit on the kit and think if I can see something, they are testing using the same substance I'm spitting on the kit. But then you say, swab on the upper gum to pick the mucosal transudate and then swab on the lower gum. But, we have cases like this. Some 3%, some 10 men said, I passed on the teeth, and that could be, those are some of the results that could have been probably wrong. So after testing, this is what we found, that 51 men out of the 352 that tested, that is 14.5, were HIV positive, 14.5. But we realized only 16 were testing for the first time. What happened to the other people? These were some of the men that actually came in when they were already positive. And the good side to it is that we're able to determine prevalence. Maybe that's the good side. But in terms of our primary objective, we didn't want to get men who are positive, already positive. Wanted people who were negative at enrollment, and then we would see how many of them would test positive in subsequent visits, and this would be linked to care. So we asked those 16 who were positive first time, did you go for confirmatory testing? 88% said yes. And the number of men with confirmed results was 50%. Now, this could probably scare people, and it's like, the sensitivity of the kit. This wasn't really a measure of sensitivity. We found that only 7 were confirmed as positive out of the 14 because some of the results, and this is what I want to tell you, some of the results were read incorrectly by a member of our study team. So the study team member a respondent would say, I see negative results. And then the study team member would say, but I think I see another line. This could be positive. Now, that issue of could be positive led us to include them among the positives initially, but when we sent them to confirmatory testing, all of those who said they had seen negative results turned out to be negative. So the problem was on our team and not on the kit. So the 50% does not in any way mean that the kit was inferior. Now, again, basically on the same point, if you look at inter-reader reliability, if you look at HIV results as read by a member of the study team, and then HIV results as read by the respondent, this is where you can see that although 48 were positive, read by a member of the study team, the respondents had 30, 30. Respondents had 33 in the total positive, was 33, if you went by the respondents' reading of the results, but the study team members saw 48. Now, the extra 15 are those people that I'm talking about, where a study team member would insist that they are seeing a second line. And the instruction is that when you see 2 lines, even if the second line is faint, regard as reactive, refer for confirmatory testing. So that was the problem. And then for the negative, we didn't have much of a problem with the negatives. The respondents, 293 respondents said they were negative, and then 285 were negative based on the study team members' reading. But at the end of the day, we were able to determine that 92% of the results that were negative were correctly read by both, but only 59% were correctly read by both for the positive results. For the problem that I told you about, which was a problem on our side, insisting that there's a second line when there was no line at all. So linkage to care of the 7 men, you see, we talked of 7 men here, 7 men who were confirmed positive. So of the 7 men that were confirmed positive, 5 of them initiated HIV care after follow-up 1. 3 of the men were still in care at the last follow-up visit 12 months later. Of the 5 men who had initiated care, 1 out-migrated, while the second one defaulted on their treatment. That is why we have 3 of the 5 reaching the last 12 months still in care. So the last bit was acceptability of secondary HIV self-test kits distribution. This is already published in PLAS Global Public Health. What we're interested in the men who received the 2 kits, did they give them out and who did they give, and so on and so forth. So the percentage of members that got 2 kits was 80%. Some 20% only got 1 kit. And the reason they got 1 kit, although the instruction was to give 2 kits, was that members would say, when I contacted my social network member, I realized he didn't have a partner, so I gave him 1 kit. That wasn't our instruction. Our instruction was give 2 kits, but somehow peer leaders introduced in another instruction. If somebody doesn't have a sexual partner at the time I give them kits, I give them 1. So we ended up with 20% getting 1 kit, but 80% got 2 kits. So those that received the 2 kits, 64% gave out the second kit to someone else. And this was higher in Buvuma district than in Kalangala district. Now, of those that gave out the second kit, 75% gave the kit to a sexual partner who was female. 75% gave them to a female sexual partner. Again, higher in Buvuma district than Kalangala district. And of those that gave out the second kit, 98% of the people who were given the second kit accepted to take the kit. We put our cutoff at 80, but 98% who were given the second kit accepted to take the kit. And 75% were female, as I've said. 87% of those who received the second kit, of the females who received the second kit, used the kit to test for HIV. 6% were positive, and 29% linked to care. So in a way, we're also indirectly trying to see, is it possible to use this approach to, previously research has indicated that it's possible to distribute kits from females to males, because we have done that. You give the kits to pregnant women, they take to their male partners. But in this one, we wanted to see, is it possible to give to the men and they take to their female partners? And I think that's what we're trying to say. So as I come to the end, these are the implementation challenges. There were gaps in enrollment, which I mentioned, because we are using a self-report during screening. Because of that, 35 men who were already living with HIV were self-reported as negative, and there was no way we could confirm that because it was a self-report. So when we made a follow-up with the health facility and checked the HIV treatment status, we realized that 28 of these 35 men actually were interviewed at follow-up 1, but they were still insisting they were negative. So that was the problem we had at the time. One way to address this could have been possibly do recency testing. If we had a test kit to test and determine how recently you are infected with HIV, we could probably have eliminated them after the baseline visit. There were high losses to follow-up, 36%, largely due to out-migration. And we also enrolled men with non-positive status. Some peer leaders gave out 1 kit. That was not part of our instructions. Our instruction was to give 2. And they ended up giving 1, giving the reason that the person they were giving the kits to did not have a partner at the time. But also there were differences in the interpretation of results between the respondents and our study team member, which led to another 7 people going for confirmatory testing who should not have gone for confirmatory testing because they're already negative. So in conclusion, this peer-led testing intervention is feasible. At least you can distribute the kits and reach a population in the fishing community. The men in the fishing communities are highly mobile. So if you wait for them at the facility to test them from the facility, you will not get them. So that's why we came up with this approach. The peer-led self-testing intervention is also acceptable because men can use the kits and test for HIV. And the sizable proportion of them will be newly identified. and linked to care, new positives and linked to care. We also found that secondary distribution is possible to give men kits and they take to their female partners. When we did the one of female to male, the fear was that the females were concerned that if we deliver the kits to our men, having not told them prior that we are coming with kits, it may cause violence in the home. Because in our settings, men have an upper hand. So you don't just bring your things home when the male partner is not informed. Now, this one is another way of looking at it. How about if we get the kits to the men now who have control to take to the female partners? Will they deliver the kits? Will they fear that by giving the kits to the female insists we test together, and so on and so forth? So that's what we're trying to test. And we found that it is possible to distribute the kits. We did not interview the female partners to find out if they were forced to take the kits. That's one component that we need to follow up in subsequent studies. So in terms of next steps, we have submitted an application to the National Institute of Mental Health for funds, and our intention is to extend this approach to remote fishing sites. And then we'll also continue to assess the preliminary effects of using already trained peer leaders as peer trainers. We want to see whether you can cascade, use those trained already, and then use them as trainers of the new group of peer leaders. If that works, then we know we'll have created an approach that can be taken on by the Ministry of Health through that cascading approach. And then we intend to apply for funding in future for a large cluster randomized trial to assess population level effects of this intervention in different fishing communities. So this is to acknowledge all the people who participated in this study, but most importantly, EDCP2, which funded the study. Thank you very much. And yeah.
Thank you so much for that really great presentation. And let's see if there are any questions in the room, and we can also look at the chat. I'm not sure on a few things.
Okay. No, Nifa. So that
Okay.
Yes, thank you so much for a great conversation or lecture. I have a number of questions, but I'll just start with two. First is, what is where yes, how the cost effectiveness of the and what was and secondly, for your next study, I'm just wondering if you could, if you're thinking about scale up or going to the government, then this idea of interviewing all the group members by the study team. So I said, anyway, you can test if you don't do some of those things, if it was just sort of like distribution to trained peer leaders, could they be responsible for identifying group members and so on? Could you remove that, all that extra study team aspect if we're really thinking of a scale up? And the third is, with regard to the women, I was intrigued that only 29% were linked to care of those who apparently tested positive. That seems very low. So I was wondering if you could speculate about that and if there would be any way to do that.
Okay, thank you. The cost effectiveness we did not do. This is one of the things we need to think about. We didn't determine the cost, but looking at the basic cost we use to deliver the kit, I think each peer leader will receive about $5 through the process. $5 to facilitate them to move about within the communities if they needed to meet their social network members at another location, or for the time they have put in terms of time compensation, So we spend about $5 per peer leader for the distribution process, and which is quite low. I think if we were to compute the cost, probably wouldn't be much. Most of the cost would be on our side because we had to hire vehicles to go to the islands. The ferry is free of charge. Once you come with your car, you just load onto the ferry and you cross. But we had to hire vehicles to keep us in the islands for all the period, because you can't say, please bring us here and then you go back and you come back for us, because that will be again another cost. So we did not do the cost effectiveness, but that is a bit of insight on how the costs were. On the side of distribution, about $5 per person, and we had about 22 peer leaders distributing kits. So on the side of the cost, and I think that's what we need to emphasize to the ministry, that whereas we had most of the costs on our side, the ministry can take it up, because the ministry has already what they call a community health work strategy. They're already working with community health workers, not these ones, because we didn't want to encroach that. We actually trained a different group of people, but it is similar. They are all working in the communities. So if we tell them, if you can invest in your whatever amount you have, and the facilitation for the peer leaders is on about $5, and they will do the good work, they will distribute the kits. The second comment was on the, again, scaling it up. Of course, there are things we did because this was research, but if we finally scale up and find that this approach is really good and can be taken over by the ministry, what we need to tell the ministry is that the peer leaders can identify the people they know in their own social networks, and as long as you give them the kits, they will distribute them and distribute whoever they can come for the kits. Yeah, that's very important. We don't need to put in those controls at the point when the Minister of Health takes it over. But for now, since we are only trying it out, this is the second group we are testing with this approach. The first group was in Kasensero, the first place where HIV was identified, and then we moved to these 2 sites. Now we applied for funding. Forget the funding, we'll try to see. These sites are a bit closer to the main, for an island, there's always for these islands that we targeted, they had the district headquarters. So if the district headquarters was about here, there's always a main health facility that we worked with, and the location where the study was is about close by. So we think that probably high uptake and high everything could be influenced by these people already exposed to other interventions because they are closer to the district headquarters. So I want to try it out and see if we went to further in the leg and to other remote sites, would we still get the same? Now, when we answer that, then we will tell the ministry, this approach not only works for people who are closer to a district facility, but they also work for those who are further away from the district headquarters. Yeah, the issue of 29% females, yes, that was a concern to us. One thing I can think of is that the women themselves in the fishing communities are mobile. They're actually as mobile as men because they trade in the fish, and again they get the fish and move to different places selling the fish. So they are also mobile. That could be one of the reasons that we were not able to get. And one of the challenges we still remain with, which we want to address if we are funded in the next grant, is the issue of how do we improve linkage to care in this highly mobile population. And one approach we want to try out is the use of community outreach clinics. We want to see if we work with the main health facility in each island district, is it possible to do community outreaches to those remote islands and probably be able to meet those people before they move out to other locations and be able to link them to care. If we wait for them, now this is where we were waiting for them at the main facility. Although the testing was in the community, these people had to go to a main health facility to link to care. So that could be one of the reasons that we have low uptake, low linkage to care among females. Even among males, it wasn't as high as we expected because some of the men could not come to the facility to get linked to care. So yeah, that's what I can say for now.
Yeah, thank you very much. I know it's a couple minutes over. We're going to take one question from the chat and then one from here if people can stay. We understand if you can't. Yes, and now I have a mic. So this is our friend Kreish Mubiru, who we know well, asked, thanks for the presentation. Doctor, did you register any female partners who tested positive as a result of the HIV self-testing kit distribution by their male partner?
Yes, I said 6% of the females who received the kits actually tested positive. Yeah.
Okay, thanks. And one quick one, what was the time points for the follow-up from Dallas Swendeman?
Oh, okay. The first follow-up was 2 months from the baseline visit. Then the second follow-up was 6 months later, and the third follow-up was another 6 months later. So the first follow-up was closer to the baseline because we wanted to find out, did the people test? And then the other subsequent follow-ups were to see how many of them linked to care, how many of them was, still follow up.
Okay, thank you. And I'll ask Gregory, you sure? Anyone else in the room? Then maybe you get the last question.
Great presentation. One of the questions following up with the female, or overall, when a person tested positive, you said the linkage, how was they linked to the provider? Was it just a warm referral, or just a handoff, or say, we're going to take you to this location? And then how did that, or you could say maybe, how was the response when someone did test positive? People say, oh, okay. Or, some people say, oh my God.
Okay, thank you very much. The first one was the females. Now, we did not escort anyone, and probably those are some of the approaches we need to find out. We did not escort anyone to a facility to link to care. We only gave them self-referral cards. We gave them self-referral cards. The cards had the name of the facility, the name of the provider. We had someone we were working with at the facility who would be responsible for receiving those that had that card. If they show the card, then they would know, oh, this belongs to the study that they talked about. So it was up to them to go to the facility. Now we waited to see them. So 29% of the females turned up, and 75, I think it was about 70% of the men who turned up. So in both cases, we are below the 95 targets. And so there is a need to really look out for other approaches to get these people to care. Like one of the approaches we are thinking of is the use of community outreach clinics. Because the facilities in these settings normally go out to do community outreaches. So if we work with them, we could probably get the men and the women as well. Now, reaction after the positive result, I don't know, because we didn't ask this question, but yeah, we didn't ask this question.
Where they are, how did they react?
But
but so you can't tell because just out of, or any feedback from the peers say, hey,
we didn't get anyone saying they were really surprised. I think we had a question. Did you have any regrets? Why you took the kit home? I think when we analyzed that, I think about 5% or so said they were regretted why they took the kit. So it's like most of them were like, no, we did not regret at all. So if you use that, possibly they were not surprised. And the other reason they were not surprised maybe could be these are places where sex and sexual interactions happen every time, every day. There is even what we call sex for fish. If your female traders can exchange, you have sex the other side, you get the fish. You don't need to pay. So they are engaged in interactions that could probably lead them to believe that maybe they're already positive. And that reminds me one case in the other site we started with, where somebody who tested positive almost refused to take the results. And was like, negative, tested negative, said, no, I can't be negative. For me, I already know I'm positive. No, given the way they live, their way of life, characterized with heavy alcohol uptake. And we actually have another intervention. We're trying to target alcohol-heavy drinkers. the binge drinkers. So there's heavy alcohol drinking, there's, commercial sex and all that stuff. So maybe they were not surprised, but that is me saying, it's not them saying. Yeah, thank you.